Hello, welcome to this segment which discusses some features of the care for patients with diabetic ketoacidosis. In our discussion today, we will discuss who is at risk, what DKA is, why it happens, and how we treat it. Let's consider a case. A 23-year-old male presents to the ED with nausea, vomiting, abdominal pain, and shortness of breath. He has a history of sepsis and diabetes. He's currently between jobs and hasn't been able to afford his insulin. The differential diagnosis for our patient is broad. You notice he is hypotensive, tachycardic, and tachypnic. Is he hypovolemic? Is he septic? Why is he tachypnic? Does he have pulmonary infection? Or could he have a PE? Are there cardiac causes for his abnormal vital signs? Then you notice the blood sugar. Is it the chicken or is it the egg? This patient has a lot of abnormalities in the primary survey. His breathing is abnormal. Maybe he needs some oxygen. The circulation is certainly abnormal. He is hypotensive and tachycardic. Although we don't know yet why he's in shock, this needs to be addressed quickly with fluids. DKA, at its root, is a lack of insulin. The body has access to plenty of glucose, but not enough insulin to process it. This leads to an increase of counter-regulatory hormones, such as increased glucagon, increases in gluconeogenesis, and the production of ketones to feed the brain. The net effect is increased glucose. Osmotic diuresis can lead to significant volume loss through urinary losses. On top of that, many patients with DKA are vomiting. Depending on the sources that you read, the average patient with DKA will be down 5 to 7 liters of fluid. It's safe to assume an element of hypovolemic shock for these patients. Some will display it overtly. Plan on a 20 milliliter per kilogram volume resuscitation at a minimum. Whole body potassium stores will be decreased from vomiting and diuresis. Remember that when we measure potassium, we are seeing just the extracellular potassium. Subsequently, the lab we see is a poor indicator of potassium stores. And just to complicate things, remember that potassium and hydrogen trade places at the red blood cell during times of acidosis, so our reading will be falsely elevated. What's the implication? High potassium is probably okay for a bit. Normal potassium is already too low, and low potassium is dangerously low. Be ready to replace potassium, but my personal preference is to make sure they can make urine first. I like to know that the stupidest organ in the body, the kidneys, is going to work. There is no benefit to an insulin bolus. Once the fluid resuscitation has been completed, start insulin at 0.1 units per kilogram per hour. Insulin should be continued until the acidosis is corrected, even if that means using a glucose substrate such as D5 to prevent hypoglycemia. Bicarbonate is rarely indicated unless the pH is less than 7 and there are signs of hemodynamic compromise. Usually, correcting the underlying issue will correct the acidosis and improve the pH situation. Also, bicarbonate administration is associated with a higher incidence of cerebral edema. Respiratory compensation is a huge reason people in DKA stay alive. If you must intubate them, remember that they will try to die when you paralyze them, and it's not a learner's airway. Also, remember to bag or ventilate at the same rapid rate the patient had before you took the airway. Failure to do this will lead to a rapid drop in pH and a clean kill. Clean kills, despite what the name suggests, are dirty. Cerebral edema is an important cause of death in patients with DKA. Suspect it in patients who are difficult to arouse or who have other focal neurologic deficits. CT findings will lag behind clinical findings. There are some studies out there that suggest a correlation with speed of volume resuscitation in kids that may impact cerebral edema. That is, the faster we give fluids, the more increased chance of cerebral edema. There are also some good studies that seem to debunk this. Just know that the debate is out there and be judicious. DKA always has a cause. Often it is medication noncompliance, but can also be from things that increase physiologic stress such as MI, pneumonia, UTI, abdominal catastrophes, or septic shock. So make sure to take a good history, do a good workup, and try to figure out what set it in motion. DKA is a complex endocrine emergency that emergency providers will see routinely. Although sugar is definitely part of the problem, it is not the main thing, so don't chase the sugar. Remember that these patients are volume depleted and require resuscitation. Avoid intubating when possible. find the cause. There is always a cause. I hope I've been able to shed some light on the mysteries of DKA today. If you want more information, there are many fine sources on the topic. Thanks for listening.